So today we have Rena Liz Courtney, PhD. She is going to be talking to us about the Veterans Health Administration. They're kind of their integrated and interdisciplinary pain care, which is always interesting on our ECHO. So we're excited to have her today.
All right, we have some great upcoming talks. August 13th, we have Dr. Leslie Hayes, who has spoke on this ECHO before, talking about genetics and opioid use disorder. The 27th, we have Melissa Weimer, who we met at ASAM, talking about alcohol withdrawal and ambulatory versus inpatient. And then one that you're going to want to encourage all of your peers, docs, providers, prescribers, pharmacists in your clinic to attend is going to be the September 10th session where Dr. Isaac Marsolik talks about buprenorphine for pain management. And then September 24th, we have Proof Alliance speaking on fetal alcohol syndrome. And if you want to check out other echoes going on in the state of Minnesota, feel free to click the link at the bottom of this slide when Katie sends out all the things.
And those other echoes are pretty good, but they're not quite this fun. So we'll just say that. So again, if you need
static, apparently they're missing the static.
Yeah, they won't have static like I'm having today. Remember, if you have any questions or problems or difficult cases, feel free to call. Love getting those calls and helping you out. So call Erin or call myself, or if she can't answer it, she'll move you on to me. So please feel free to reach out.
All right, just keep in mind that Stratus Health is the home to the core webpage where there's policy, protocol, the opioid manual, anything that is like workflow or policy related. Feel free to check this out before putting energy into reinventing the wheel. We probably have something that we can use to help. And with that, we will turn it over to Liz.
Erin, sorry, just quickly, we do have a poll, like a quick poll before we go into the presentation.
Oh, forgot about that.
Yep, me too. Thanks, Senka. So Senka, she needs to there we go. Okay, Katie's on it. Is everyone seeing the poll on the screen? Nodding. Yes, no. All right, cool.
So just two quick questions to understand a little bit more about our ECHO audience, so we can ensure we are getting the content that's relevant and important to you. So this is the first question, so please go ahead and answer, and then we'll move on to the second question.
All right, did everybody click? Good. All right, I'm seeing thumbs up. Thank you.
Katie, are you able to display the results of the first poll?
Yep, 1 second here. Can you all see that?
Yeah, thank you.
All right, let's move on to the second question.
Great.
Really good. Thank you all so much for filling this out. It's good to get to know our audience. So, Erin, back to you.
Thank you for the reminder, Senka and Katie. I would have forgotten about that completely. All right, here we go.
All right, I'm just doing a quick tech check. Can everybody hear me, see me, and see the slides?
Loud and clear and static free. We're good to go.
Magic. Okay, good. All right, let's hope it stays that way. Hi, everyone. Again, my name is Liz Courtney. I am a clinical psychologist by training, but I also wear a few other hats. I am in administration within the Veterans Health Administration. Specifically, I run a chronic pain program at the Salem VA, which is in Central Appalachia. In Salem, Virginia, right about the middle of the state. I am also a clinician investigator, so I run randomized clinical trials on interdisciplinary and behavioral interventions for chronic pain. And as we have learned, there's a very big overlap between chronic pain and folks who are using medications for opioid use disorder. So I was really excited about the opportunity to share some information about pain as it pertains to the populations that you might be serving. And I'm hoping my presentation style is pretty interactive, so I'm excited to be able to chat with you guys as we kind of work through today. Specifically, what I'm going to be talking about is a chronic pain program that we developed here at the Salem VA, which is pretty innovative for rural veterans. An important part of my background is that I grew up in a rural area. The nearest mall was an hour and a half in any direction, so you might know the kind of place I'm talking about. And really, the goal for Prevail was to come up with an efficient model for interdisciplinary pain care that wasn't going to create more barriers for rural folks like myself. So, like I said, we'll go ahead and dive in and get to it. So give me just a second here, make sure it's going to be happy. Just a couple of disclosures. I do have funding both through the VA and our academic affiliate and NIH, and then I've received travel support for different presentations in the last couple of years. And I currently serve as the co-chair for the Behavioral Medicine Committee with the American Academy of Pain Medicine. That's a typo. So we've got three things that we're going to kind of tackle in the next little bit together. The first one is to talk about whole health, specifically the VA model of whole health can relate to the etiology and treatment of chronic pain. Some of you might be kind of scratching your heads and wondering why we're talking about chronic pain in a MOUD echo call. But what we do know is that a significant portion, matter of fact, it's about 72% of folks who are seeking treatment for a substance use disorder report chronic pain. And a systematic review in the last couple of years revealed that around 45% of people who are being prescribed medications for opioid use disorder also report chronic pain. And what we know between the two things is that if you have chronic pain, outcomes are pretty rough, right? We've got impacts on functioning and what have you. High risk for suicide. Same thing for opioid use disorder. It turns out that when you put those two things together, again, it's like the perfect storm. 1 + 1 really does equal 2. And so this is an important patient population to talk about how to optimize our strategies for treatment. The second piece is to talk about interdisciplinary team care for chronic pain. I'll give you the background on why that's important. But we also want to talk about an overview of a model for interdisciplinary pain care that was designed specifically, as I mentioned, for rural veterans who tend to experience lots of barriers to care. I recognize this is not a VA talk. So my goal today, as I was putting these slides together, was really to come up with some application points for folks, even if you're not working in the VA, even if you're not working in a pain clinic. So I hope that you'll find this relevant. Let's talk a little bit about chronic pain. As I mentioned, this is pretty prevalent in folks who are receiving medications for opioid use disorder. But let's back up one more step and talk about the definition. The definition that I've got on the slide here was put forth by the International Association for the Study of Pain back in 2020, and it was pretty contentious, actually. It's the first time that this definition had been overhauled in decades. And I imagine that there's a couple pieces of this definition that might be sticking out to you as different than what you learned in your training for pain, if you learned anything in your training about pain, which most of us didn't. The way that they define it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, this is different than what most of us got taught, right? Most of us got taught that when pain occurs, it's because, say, I put my hand on the stove when I'm cooking dinner, being klutzy, that those nerve endings in my hand are going to send that pain signal through my arm into my spinal cord and shoot up to my brain. And that's the experience of pain. What we've learned is that this is a whole lot more complicated, that the emotional experiences with chronic pain are part of the experience. You can't actually separate out the two. We use a biopsychosocial model when it comes to chronic pain. The biological factors and the neural processing is important. However, the emotional experience of chronic pain, the thoughts, the emotions, all of that stuff plays into the way that a person experiences pain. Same thing with the social aspects, but we'll get into that. The second piece that tends to stand out to my patients whenever I'm talking about pain is this actual or potential tissue damage. It turns out the brain is very invested in making sure that you are safe. And so sometimes, in order to keep you safe, it'll send you false alarms. And so our job is really kind of tricky. It's trying to figure out with our patients when the brain is sending false alarms versus when a true harm alarm is happening. So we also know that this is really prevalent, right? We talked about specifically in the medications for opioid use disorder population, it's about 45%, but 20% of Americans experience chronic pain, which they define as greater than 3 months. It is more prevalent in veteran and rural populations. So we've kind of got the jackpot going on around here, working in central Appalachia with rural veterans. And we know that this costs society billions every single year. So I'm curious, and again, I tend to be pretty interactive when I speak, so I'm hoping we can use the chat function here. I'm wondering what comes to mind when you think about traditional chronic pain treatments. And I recognize we've got folks from lots of different disciplinary backgrounds, so feel free to kind of use the chat, type in what comes to mind for typical treatments for chronic pain. Fruit basket for the first person who says opioids specifically, right? Medication, absolutely. Keep them coming. Opiates, there you go. Gabapentin, keep them coming. PT, there we go. Antidepressants, tramadol, okay, keep them coming. Injections, all right, there we go. Heat, cold, acupuncture, so some complementary and integrative health showing up. Nice. Surgery, yep. Okay.
I think lately we'd have to add kratom.
Ah, there you go, right? Substance use of choice. Yeah, ketamine. And it's interesting. What we know is that a lot of folks, it's around 25% of people who have chronic pain tend to cope with that using some kind of substance. So absolutely, kratom's on the, I see psychotherapy. If we're massage, okay, you guys are a wonderful audience. Most of the time when I ask this, I get opiates, medications, surgery. And it's interesting, right? If you take a look at the literature, there is strong evidence against initiating opioid for chronic pain. That is a no-go. What we have learned is that that is not an efficacious approach because chronic pain is just so complicated. So great job on this first question. We've got some more coming, so stay warmed up. All right. So as I mentioned, the typical approach for chronic pain is that, say, the veteran or the patient goes to their primary care provider, because this is actually the number one reason why people go to their primary care providers is pain. They show up and they say, okay, doc, I've got this low back pain. I've been doing the best I can with it for the last 20 years, but it's starting to cause issues at work. I can't play with the grandkids. I'm having trouble. Primary care provider says, well, and actually the research suggests they go, I don't know what to do, because they didn't receive a whole lot of training on what to do for chronic pain in their medical education, in their training. They say, okay, well, I'm going to place some referrals. I'm going to place a referral to physical therapy. I've heard that's good. Psychotherapy, I went to this lecture, heard that cognitive behavioral therapy can be helpful. Injections, we'll send you there. I'll get you started on some opioids just so you can manage at work. And you notice how all of this kind of becomes this shotgun approach, where suddenly I've got 1,000 appointments with 1,000 people who are going to tell me 1,000 different reasons why I'm in as much pain as I'm in, right? The PT is going to tell me that it's got something to do with my muscular system. The shrink, and I get to crack these jokes because I'm a psychologist, the shrink's going to tell me that it's the way that I'm thinking about my pain that's causing the problem. Again, I end up pretty confused. I've got a treatment plan with 1,000 appointments and I'm trying to maintain a life, right? This is not going well. And the bills are racking up, right? Because copays. And so this is not going well. Plus, I end up with polypharmacy happening, right? We started off with opioids. Now I've got gabapentin on board. It turns into a mess. So as I mentioned before, what we've learned with chronic pain is that this is super complicated, right? We've got some biological processes that are happening. Absolutely. Those are important, but they're not sufficient. the psychological factors that are occurring, not just, again, emotions, but the thoughts that people are having about pain do play into their experience of pain. Social factors are not ones that you hear a whole lot about, but what we're learning is that when people are isolated, when people are not engaged in meaningful activities, when people are having stressors in their environment, in relationships, that this is like throwing gas on the fire for pain. So again, super complex. So I'm going to give you one more model to kind of think on for a minute. In the VA, over a decade ago, there was an office established. That's what we do in the VA, called the Office of Patient-Centered Care and Cultural Transformation. What a mouthful. OPCC is the way that we describe it in the VA. And their task was to shift the VA culture from this disease model of healthcare, which we all recognize is not going that well, to a conversation that we'd have in the clinic about what's important to you, right? So rather than you come in and I say, what's wrong with you? Disease specific, right? Problem focused. We say, how can we work together on taking care of you in a way that gets you back to the things that bring your life meaning and purpose, right? That's a different conversation. As part of that task, the VA has been very busy in the last decade, rolling out patient education, provider education, and conducting research on the impact of this different approach to healthcare. They've developed this model called the circle of health. You'll see that on your slide here. And what we know is that all of these pieces of self-care really, really matter for chronic pain. Again, whole health has been defined by the National Academies of Sciences as physical, behavioral, spiritual, socioeconomic well-being, achieved through care that is interprofessional, team-based, anchored in trusting longitudinal relationships that promote resilience, prevent disease, restore health, and they're aligned with a person's mission, aspiration, purpose. Again, there's a lot of pieces going on here, but the point is people are complicated, right? We can't focus solely on just disease. So hang with me here. Back in, I gotta remember, I think it was 2022. Maybe it was 23. I published a paper that was describing how the whole health circle of health could actually be combined with a biopsychosocial model of chronic pain that's been around for a long time to describe the foundation for interdisciplinary treatment plans. So what we're going to do for the next few minutes is we're going to walk through these different factors of self-care that can throw gas on the fire for chronic pain. What I'm hoping you take from this is that as you're talking to folks in your clinics who experience chronic pain, because my money is on every other one of them having chronic pain based on the literature, that you could think about these as different tools in your toolbox that you can pull from, right? As you're goal setting with them, as you're trying to get them to function at a higher level, thinking about these as potential ways to reduce that chronic pain. We're going to start with moving the body, exercise. If you haven't worked specifically with chronic pain, let me tell you, getting folks with chronic pain excited about exercise, very difficult, right? Think about it. When you're in pain, what do you want to do, right? You want to not move. And unfortunately, what happens is that the more that you don't move, what happens to that pain? It gets worse, right? And we know this from the literature. Activity and frequent movement is super key for exercise or for chronic pain. The trick is that especially for my military folks, are they good at the boom bust cycle, right? The analogy that I like to use is the grass, right? So again, military veterans, a lot of them males, they are in a lot of pain. So they sit in their armchair and they look out the window and every day they watch that grass get a little bit taller and they know they need to go mow the grass, but they also recognize that when they go mow the grass, their pain's going to get worse. So they procrastinate, right? And we sit here and the grass is getting taller. And then one day, either the wife has nagged them or they get frustrated and they're like, I'm just going to go mow the grass. But rather than do it in sections, they're like, I'm just going to rip the Band-Aid off. I'm just going to do it all. And what do you think their pain's going to be like for the next several days? Terrible, right? So we go from I'm doing nothing to I'm doing too much, and then we crash again, right? And the whole cycle repeats itself. So this overdoing it, underdoing it thing, big problem with chronic pain. And again, this can kind of be reinforced through different habits and culturally influenced, such as rural populations that tend to be pretty hardy and just get the job done. So again, exercise. Evidence supports exercise for chronic pain, specifically in veterans, but also in other populations. Sleep. Oh, this is tricky. What tends to happen with chronic pain is that chronic pain gets worse, then you're not sleeping as much. And as you're not sleeping as much, what happens to chronic pain? It gets worse. Chronic pain gets worse, sleep gets worse. And you can see how this kind of ratchets in the wrong direction. There is a bidirectional relationship between chronic pain and sleep. The nice thing is that if we can intervene on the sleep end of it, then we can oftentimes intervene on the chronic pain side too. And if we can get those going at the same time, then this helps. So let me explain. What we typically do is we tell people, okay, sleep is terrible and your pain is off the Richter scale. But if we can get you doing some things like sleep hygiene, right? Cut back on that caffeine. Don't be looking at that phone right before bed. Then I can get your sleep a little bit better. And if I can get your sleep a little bit better, then your pain's going to come down a little bit. And if your pain comes down a little bit, maybe I can get your sleep a little better. Make sense? So we start kind of ratcheting back this other way. Sleep hygiene and cognitive behavioral therapy for insomnia work very well for this issue. The third one is nutrition. This is something that I will say, even in the last decade, we figured out is really important when it comes to chronic pain. Oftentimes, when people are experiencing pain, they've got some form of inflammation happening in the body. And it turns out that everything you put in your mouth to eat or drink either drives up inflammation or it drives it down. And dietary interventions can actually improve chronic pain. There's been some great systematic reviews and meta-analyses that have occurred in the last decade or so to tell us that the anti-inflammatory diet can be super impactful. So the anti-inflammatory diet and concept comes from this idea that when you have excess calories from fat, trans fat specifically, and sugar, that throws gas on the fire. So if we can get you eating less sugar, right, less processed foods, inflammation goes down and pain goes down. All right, now we're to the psychological components, right? My bread and butter as a psychologist. In whole health, right, in VA, we call it power of the mind. They had to give it fancy names, right? So what we do know is that mental health and chronic pain are very, very closely related. And I hate this term, and patients do too, pain catastrophizing. Anybody ever heard of that before? Can I get a raise of hands? Okay, I'm seeing some people nod. Don't use that word with patients. We've shifted in the field to calling them concerns about pain, right? So the thoughts that you're having about your pain. Much less stigma attached to that concept, right? What we know is that the way that your brain starts kind of processing that pain, if you start having thoughts like, I'm never going to have a life worth living with this much pain, or you wake up at 6 a.m. and have this thought, if my pain is bad now, just wait to see what it's going to look like at 6 p.m., that thought itself can actually drive up the experience of pain because it's driving up my stress, which is driving up my pain. So if we can kind of tackle the mental health components, we can get people involved in cognitive behavioral therapy for chronic pain. We can work with some pain neuroscience education that can tamp down some of these issues. Also treating comorbidities, because anxiety, depression, PTSD, all those things like gas on the fire for pain. The final piece is spirituality for these psychological factors. And again, this is one that we're kind of doing some more research on. The literature is very clear that spirituality is a major source of coping, not just for folks with chronic pain, but also with substance use disorders. They did a study where they were asking folks who had chronic pain plus opioid use disorder how they were coping, and prayer was the number one answer, right? So this is actually an area of life that people use pretty frequently, even if we're not asking about it in the clinic. Now, again, this can go well. This can also go poorly. It can be a major source of coping, but if somebody's having a lot of struggle with their spirituality, then that can actually drive up stress, right? And drive up pain. All roads lead to Rome. So very important for us to ask about it and make sure that we are addressing that in a way that is patient-centric. If they value that and want to get back to it, then we're facilitating those changes. All right, the last piece of this puzzle is the social aspects of chronic pain. Again, we're doing some more research in these areas, but I can tell you clinically that most of my folks who experience chronic pain are having issues with surroundings. They're in pain, so they're not cleaning the house, right? They're not keeping up with the land. A lot of my folks have farms. They're not able to do those things. And so that's really frustrating. That's really stressful. They get into this habit of overdoing and underdoing it, and we have issues. We do know, however, from the literature that hoarding behaviors tends to go up with chronic pain. It makes sense, right? I'm not constantly organizing, cleaning, so things are starting to pile. Again, if you're thinking about goals for folks who are experiencing chronic pain and are on medications for opioid use disorder, thinking about how they can address their physical surroundings can be very useful. The next piece is personal development. I call that engagement in meaningful activities. This is a major treatment target for cognitive behavioral therapy for chronic pain. We are trying to slowly increase the dose for these meaningful activities in patients' lives. And we know that the more that they're engaged in those meaningful activities, not only are they more active, but that increases positive emotion and that drives down chronic pain. So getting people engaged, keeping them active, not just physically, but also emotionally, mentally, very key with chronic pain. We know that lack of employment too is associated with higher impact pain. And what I tell my patients is the fastest way to make pain worse is to get you bored, right? You get bored, you sit there and think about how much pain you're in. Oh, trust me, it's going to get worse. So again, activity, very important. The last piece, really the last piece, is this relationship component. And we know that social support is related to adjustment to chronic pain. Oftentimes what happens when you got pain is that you tend to shut down and shut out. And the more that happens, what happens to pain? It gets worse, right? And over, I see this again in the clinic. So having folks engage in those relationships can not just help with recovery from substance use disorder, which we all know, right? But it can also help with their chronic pain. So good double bang for their buck if they're trying to get motivated. Okay, so I've talked a lot. I'm really curious. What are some examples of factors that you think can contribute to the experience of chronic pain? We've talked about the different areas of self-care, but what are some other things that you've seen throw gas on the fire with chronic pain?
Staff that
Emotions.
don't treat patients well.
Aha, for sure. Tell me more about that one.
I think there's a lot of stigma and, people very quickly assume that someone is drug seeking
Yep.
or displaying that behavior, and it just kind of spirals from there.
Oh, yeah, absolutely. Did you know the number one reason why veterans specifically reported that they were non-adherent to their medications for opioid use disorder? Unmanaged and undertreated chronic pain.
Oh.
Right? So, and you're exactly right. You try to have this conversation about, I'm telling you I'm in pain, and then somebody assumes that they're just trying to get more drugs or they're trying to switch over, and then patients frustrated, providers frustrated, right? This doesn't go well. So we got a lot of room to work here. I see emotions, poor social support, any other factors that you guys have seen throw gas on the fire here. Lack of health literacy. Oh, for sure. Right. Now let's think about the trickle down effect here. I mentioned that that primary care providers report wide across the board that they are not confident in their ability to manage pain because they didn't receive pain education. If the providers don't know this information that I'm sharing with you, how are the patients supposed to know, right? So everybody's just kind of walking around without knowledge and literacy in these evidence-based self-management principles. Poor nutrition, absolutely. Again, fastest way to make pain worse, overweight and that trans fat and that inflammatory response that we were talking about. Ooh, the let me do that for you from family and friends. I didn't mention this, but that is such a big one. I'm actually working on a theoretical paper right now with a colleague from Stanford on this concept. It tends to go one of two ways, right? It tends to be, I'm not getting enough support from my spouse because they think that I don't really have a problem. And so I have to do everything. Or it's the spouse who I describe them in the clinic as overbearing, right? So they walk in and the spouse is pulling out the chair and the person, the veteran flinches and then the person over responds and doesn't let them do anything. This is also an issue. So yes, that can go well or it can go poorly. Limited access to resources is a big one. I crack jokes sometimes that I am a pain psychologist and I'm a bit of a unicorn. Right? You hear that we exist, but you never see us because there's not enough of us. There's not enough training happening in psychology specifically for pain, as well as other disciplines. So, lack of providers is a huge, huge concern. Difficulty obtaining medical records. That is accurate, right? We talked about the traditional approach for chronic pain. I've gone and seen a million people who've had a million different opinions, and now my medical records are stacked like this. And most people don't get served in a VA where it's an integrated healthcare system. So it's my responsibility to go toting this thing around and praying that somebody's going to take the time to go reading through the stack when are they really? So yes, lots of things, right? I have a very complicated job that I love. So long story short, right? Think about all the things that can go bad and all the different options for treatment. It makes sense why you have to have an interdisciplinary team. I tell people as a pain psychologist, I have a piece of the puzzle, right? I have some answers as to why you're experiencing the pain that you are. But guess what? I have one piece of that puzzle, not all of them. So you have to have all of us working together in order to understand comprehensively what's going on with chronic pain. And the guidelines support that. So there is evidence to support, and actually I could go on a long lecture as to the evidence that is supporting interdisciplinary teams for chronic pain. My colleagues and I just published a scoping review as to all the pain interdisciplinary teams that have ever existed and been published on. You can check that out on the Journal of Public Health. But what we do know is that VA-DoD guidelines specifically for opioid management of chronic pain suggest that the role of the interdisciplinary team is key. And they also strongly recommend for a biopsychosocial assessment of the patient prior to opioids being prescribed. The VA-DoD guidelines for the management of low back pain, again, interdisciplinary teams are playing a key role. So, and referral to specialists if you don't have an interdisciplinary team. So wind the clocks back, right? It's 2021. And at the time, Salem VA, which is a very small VA, by the way, it's not like some of the bigger ones in bigger cities. We didn't have an interdisciplinary team. We had staffing issues. It was right in the middle of COVID. It was, it was chaos. Everybody remembers it. So our chief of staff was really motivated at us putting together some ideas for how to address chronic pain. I showed up with my, 1,000 ideas and pitched this concept for the first ever whole health interdisciplinary pain clinic. And he looked at me, to be honest, and said, "Wonderful, Dr. Courtney, how fast can you pull that off?" And I went, "Oh no." So 6 weeks later, we were actually doing this. We were doing something that had never been done before. The concept was that we were trying to, again, take this whole health approach. I had been trained as a whole health coach about a decade prior, not to date myself. And then with this interdisciplinary pain team approach, which we know is gold standard for chronic pain. And what you're looking at right now is what resulted. Now, I will tell you, this is not where we started. There's actually a publication that we published in the Global Advances in Integrative Medicine and Health that describes the process for developing Prevail. But this is the process as it stands. The first appointment that the veteran has is an intake with an advanced practice provider. And 3 things happen during that first appointment. They do a history of present illness, they do a physical exam, but in my humble opinion, most importantly, they do some psychoeducation as to why the interdisciplinary team approach is most important for chronic pain. What we know is that rural veterans are prescribed opioids specifically at a higher rate compared to their urban counterparts. Again, that was published a couple months ago in the Journal of Rural Health, if you want to check that out. So they again will provide some education about that interdisciplinary approach, because most of the time, this is the first time my folks have heard of that. And then if they decide that they want to engage in Prevail IDT track, which is what we call the program, then they go through 6 weeks of pain education. This is not a hoop to jump through. We actually did try it without the pain education. And it was the veterans who told us, I really wish I would have known what an anti-inflammatory diet was or what cognitive behavioral therapy was before I showed up and you said it was a good idea. So we developed a curriculum, and most of that is delivered over a virtual format. We do have face-to-face classes that run. At one point, we actually had a mobile telehealth unit that pulled into a public library at a very small town, an hour away, that you could just go watch it at the library. So trying to make that as accessible as possible, but they got to go through at least half of those classes so that they can have kind of a basic understanding as to what evidence-based self-management options are out there. Kind of a crash course in what I just went through with you guys. Then they meet with an interdisciplinary team made of different pain specialists to talk about the factors that are driving up their chronic pain, as well as developing an individualized treatment plan for how to address that chronic pain. Specifically, it's a psychologist, pharmacist, dietitian, PT, and a physician who's pain trained. Once they are finished with that initial evaluation, and we really do stick all those providers in the same room with a veteran for an hour to develop an individualized treatment plan. We've done this over 800 times since 2022 and never done the same treatment plan twice. It is entirely tailored to the veteran. Then after a month, they get a coaching call from a nurse who goes, so how's that walking going, right? What the veteran is doing is they're actually choosing 3 of those 8 self-care areas that we talked about that are related to chronic pain. And then we're placing consults for them if they want, or most of the time they're actually creating some goals for themselves. A lot of my veterans are driving 2.5 hours to get here. So the concept of coming to PT like 3 times a week is not a thing. So they might be at the point where it's like, okay, I'm going to walk to my mailbox twice a week, right? That's what I'm going to do for the first month. So we call them after a month and go, all right, how's it going? Right? How did it go? And then we theoretically, if it went well, are increasing the dose. Okay, great. Now we're up to like 3 days a week. And if we're able to do those progressive improvements across 3 different areas, imagine the kind of improvements we could get. And it does work. We'll get into that. Then after 6 months, they come back and meet with the entire team. I will say that it's an interesting time in the VA if you haven't watched the news. I should have put that on my slide. My views and opinions do not represent the opinion of the United States government. So I will say that the program has changed even in the last month. A couple changes because of staffing and because of shifts in focus and all of that. We now have 4 people that are doing that initial evaluation. And then rather than them coming back after 6 months to meeting with the team, that last appointment has become a phone call so that we can increase throughput. We're actually trying to increase the number of veterans that we're getting through the program. So as I mentioned, the veteran is encouraged to choose one out of each of these major buckets, right? So one kind of bio, one psycho, and then one social area of self-care that they're wanting to improve upon in the next 6 months. The concept goes that if I get you to pick, you're much more motivated to do the thing, right? Than me looking at you and telling you to like do the thing. We do actually have data showing which areas veterans are more likely to pick and choose, which helps us with managing resources. That is under review with the Journal of, it's pain reports, actually. So that'll be coming out soon. And we do actually have some results. So we won the VA has their own Shark Tank competition, which is kind of funny. We won semifinalist a couple years ago, and then we're listed as a best practice with that Office of Patient-Centered Care and Cultural Transformation that I mentioned earlier. What we did is we were able to decrease the number of appointments that veterans needed to do for their initial evaluation from 5 to 1, which our veterans absolutely love. 9.2 out of 10 satisfaction rating with that initial evaluation for having all 5 docs in the room. And then we know from a cohort study that, again, is under review, that after 6 months, these veterans who participated in the program are reporting improvements in pain severity, pain interference, physical functioning, sleep, they're actually dropping weight. Like lots of things are getting better. Didn't see the weight thing coming, but I probably should have. So I should also mention that we emphasize shared decision-making as part of our clinic. So I've told you about the concept of the intake, that step is right here. They get to choose between 3 different tracks in our clinic. So we don't force people to do this interdisciplinary team thing if they don't want to. I recognize that hanging out with 5 docs at the same time is a little bit much. So we do actually offer an injection track for folks who are interested in just receiving injections. If they decide that they want to do the IDT track, it doesn't mean that they won't get injections. It means that that'll be part of a comprehensive plan if it's appropriate, but it won't be the only modality. And again, research strongly supports not using unimodal treatment for chronic pain. The last piece is an active management of pain arm. It's a group that's co-taught by a physical therapist and a psychologist, and really goes into pain neuroscience education and the basics of cognitive behavioral therapy. That has been rolled out by National VA. So I'm going to shift gears a little bit and talk about outside of Prevail IDT track, because I think it's important to think about how the program fits into the setting in general. I call Prevail the Center for Chronic Pain because we do clinical treatments, right? Some pretty innovative ones that we're publishing on constantly, but that's not the only thing we do. We also conduct research to make sure that the interventions that we're offering are making an impact on the veterans that we serve, and that we're sharing that information publicly so that people can learn from our mistakes and learn from our best practices and implement them elsewhere. The third piece is education. As I mentioned, nobody knows what they're doing when it comes to chronic pain. So we are very invested in making sure that we're providing training to folks across disciplines, including pharmacy, MDs, DOs, psychologists, you name the discipline, we probably got them running around. We also do provider education to our folks who are on staff. And then we do consultation for folks throughout the hospital, including medication consultation. And we also do like pain board for folks who are coming in for surgery. We've got some qualitative improvement studies going on right now. And what we've done, I should have also shared, other hat, I'm the pain point of contact for the Salem VA, which means that if it's related to pain at the Salem VA, it comes across my desk. What we've done on that administrative side is we've really kind of gone from the shotgun approach of like, you're coming into primary care with pain and I'm just going to send you to 1,000 things, to us creating really innovative ways to reach patient populations who are at the highest risk for adverse events, but them all turning inward towards Prevail IDT Track, right? We know that that's the hub, that's the evidence-based approach for chronic pain. So the goal is, how do I go to, and literally we have services that go to our inpatient substance use units and provide some pain education to get them referred to IDT Track as fast as possible. That's DOM Fast Track. We've got a manuscript that's going under review the next couple of weeks with addiction. So that's the idea, right? And I realize you guys are not working in VA, but this concept of thinking systematically as to how do I get the most high-risk folks to the most evidence-based thing as fast as possible is a concept that I think more folks need to adopt. And I could talk for a long time about these different innovative sort of things that we've done, but I don't have the time. I do want to talk about Restore real quick, because that one was actually just published in Federal Practitioner. I think it's coming out next month. So it's kind of like a mini version of Prevail. What we recognize is that Prevail was working real well for everybody except folks who were, had chronic pain and opioid use disorder. What tended to happen is they'd come in and then we'd come up with a beautiful treatment plan. And then 55 minutes in, they would look at us and go, great, now where's my pills? Right? It'd get real awkward. And so what we came up with was a sister project called Restore. We do a MD in the room, a psychologist, and a pharmacist. That appointment consists of a psychologist doing a diagnostic evaluation for opioid use disorder, providing that veteran with some normative feedback, non-judgmentally, and saying, okay, yes, started with chronic pain most of the time, right? And then suddenly you were taking these opioids to help manage that pain. And then now we suddenly have this other thing that's creeped up. So now we've kind of got two issues you've got to tackle. And we're going to talk to you about medications for opioid use disorder. But I recognize that this is the place where it started. So I also want to talk to you about some options we have for how to get that pain under control. And that's when we provide, in a motivational interviewing sort of way, a conversation about Prevail IDT Track. And we know that it works. So we took a look at the first year, and 89% of the people that we had that conversation with agreed to try interdisciplinary team care. And 50% of them actually did it, right? They actually went through with the program. So we were really excited about that. What that showed us was that these folks that have chronic pain and opioid use disorder need some extra support in order to get engaged with chronic pain care, and really receive some education non-judgmentally. I know, Erin, you were talking about stigma, right? Like we have to kind of set up that conversation in a way that doesn't scare them off, right? And gets them engaged with care that can address the root of the issue. So I recognize my time is winding down. I want to have time for questions. Just a couple of kind of nods to our collaborative partners. I've been so thankful and humbled at the number of folks who've kind of come out of the woodworks to take a look at Prevail and the impacts of our innovative programs across the spectrum. We've done lots of presentations at national conferences and things. It's actually why I was at the conference I was at, where I met Erin at the National Rural Health Association. And so lots of publications. I know that you guys have the slide deck. You can feel free to take a look at these DOIs and do some background reading. But in my humble opinion, the cooler stories come from our veterans, right? Research impacts are important. But this is actually a picture of a veteran who went through our program and was kind enough to do an interview with AARP magazine back in October of 2023. We were labeled as a breakthrough in medical a medical breakthrough in chronic pain by AARP magazine. They did a full spread feature on us. We've also had some stories come out through NPR and through a couple different things where veterans have been able to share the impact that Prevail had on their lives, which is at the end of the day why we do the work. Okay, I got 2 quick things to give you before we jump off. The first one is handling the skeptic. Will you guys just raise your hand? Like, it is super hard talking about chronic pain, like describing why seeing a shrink or like why seeing an interdisciplinary team is really important. So this is a tip and trick that I use in the clinic almost every day, and you can feel free to steal it. The kind of spiel that I do is I ask the person to tell me all the things they've tried to manage their chronic pain, right? And I just listen. I actually grab a sheet of paper and I start writing down the things that they're telling me. And usually the list goes something like this. I've had 6 back surgeries. I have tried like 18 rounds of physical therapy. I have tried every medication known to man, and they keep going and they keep going. And so I make the list, right? And when they get done, I kind of stop and I go, you know what I notice? I notice that almost all of these things, and sometimes it's all of them, are a biological approach to chronic pain. And the hard thing is that we figured out this is so much more complicated than we used to think it was, right? We used to think that we could just do surgery and bam, pain's better. Or we used to think we could just give you a pill and bam, your pain is better. It's so much more complicated than that. But I want to see if that's actually your experience. So hang with me, right? If I have, well, what happens to your pain, right? So if you get mad or you get worked up about something, what tends to happen to your pain? Every single one of them looks at me and goes, it gets worse. And I go, interesting. So it sounds like some thoughts and emotions do actually play into your pain. But let's check it one more time. Say I've got 2 different x-rays from 2 different people, right? They look the exact same. Are those 2 people in the same amount of pain? And every single time they look at me and they go, well, no. And I'm like, well, why not? Right? Like, if it's just a biological thing, then these 2 people should be feeling the same thing. Why not? And they go, well, because they're different people. And I'm like, oh, so people thing matters, right? Like personality and emotions and thoughts. Sounds like psychology does play into this. But let's try one more, right? What happens to you when you're having a bad pain day? Do you want to go out and play with the grandkids and go have fun and go make some friends? Nope. You want to shut down and you want to shut out. And the more that you shut down and shut out, what happens to your pain? And every single time they look at me and they go, it gets worse. And I go, okay. So basically what you're telling me is that there's biological stuff happening, sure. But we've been inadvertently ignoring about 2/3 of the problem. And I'm afraid that you're only getting like 1/3 of the results, right? So what I'd love to do is I'd love to be able to refer you to a team that can actually take a look at across the spectrum, all the things that are throwing the gas on the fire here and ways to get you better. I'm imagining that they've got some options that you might not have thought worked or were related at all to your chronic pain. I don't have actual data, but I can tell you that presentation tends to go pretty well. Couple of quick things just for you guys to actually take with you. The PEG is a really simple screener. It's 3 questions. It's got amazing validity and reliability data backing it up. 3 questions. We've all got time for 3 questions, but it'll give you a good sense as to not just the pain severity, but more importantly, pain interference. How much is pain actually getting in the way of their life? And you can track that over time as an outcome measure. We also use the personal health inventory. One of the questions that I get all the time is, how in the world do you get 5 docs in one room to get all their stuff done in an hour? The personal health inventory is my key to success. This is public domain information. You can Google it, personal health inventory. It's developed by the VA. What it does is that it asks the veteran to grade themselves from, they use 1 to 5. I use A through F, right? Because I got rural veterans. But they identify how they're doing in these 8 different areas of self-care. And then what we do is, again, I ask them, so which ones do you feel like you'd be interested in doing better at in order to get that chronic pain under control? And it can start the conversation around some lifestyle changes that they can make in order to manage that chronic pain. We don't probably have time for my last question, but I do want to pass along another resource. SAMHSA has some great information about how to manage pain with adults who might be in recovery from substance use disorder, so particularly relevant here. There's also one of my favorite websites is the VHA pain management site. It has got continuing education for providers. And so if you're wanting to learn more about meds or non-pharm or complementary and integrative health modalities, I saw some folks throwing out massage and acupuncture. all that information is cataloged here on that site, and that is public domain. I want to thank you guys very much for the time and the opportunity to come share with you. I love talking about this stuff. I love getting to watch veterans come back to life. If you want to know more, if you've got questions and you don't want to share here, then there's my email. I also have a Twitter account that I try to keep updated with some cool stuff that we've got coming out of the clinic. So I'm happy for you to follow me there. What questions do you guys have before we wrap up? I see a couple.
There are a few in the chat here, Liz, and I think Brian's comment was the first one that popped in after the last we had answered.
Yeah.
So who does phone coaching? CHW nurse? Who provides pain school? Curious if those encounters would be billable outside of the VA's infrastructure.
Yeah, that's a great question. The answer is yes to the last one. So we have a nurse navigator. She is an RN level trained nurse who does the coaching calls. She does have some training in whole health and motivational interviewing. The pain school is taught, it's funny because that's changed over the years. Back in the day, I taught all of them. Since life has gotten a little nuts, we now have another psychologist who teaches, as well as a dietitian, actually. At one point, we also had a social worker teaching. So that one is not discipline specific. It's, a curriculum that we developed that can be taught by anybody. We've got pretty specific notes that they can kind of follow. The other question is about billing. So what we do, it depends on the discipline. If it's a psychologist or a social worker for pain school, we bill it as group psychotherapy because oftentimes we're doing interactions that are therapeutic. We do have a dietitian who uses, that's a different conversation. They have a whole different way of capturing their workload. And then the phone coaching goes in as I can.
Sorry.
That's okay.
I'm in a webinar, so I was trying to be quiet.
Oh, and actually, I think we can hear you. You're not on mute, Kelly. Okay, so the phone coaching is it's a phone call by a other healthcare professional that we bill for. So that is WRV generating. And then, Erin, thank you for pointing me to the chat. I do see a couple more. Are there particular types of pain that less often respond? That is something I'm super curious about, especially with all of the literature that's come out recently on nociplastic pain. My guess is that this is super beneficial for nociplastic pain, but because that is such a new construct, we haven't had the time in order to kind of catch up and figure that out. This is an area that I'm hoping to research very soon. We've got a randomized clinical trial going on right now that I'm wanting to look at. And I'm going to have to take a second to read through this next one. Emotion code. Yeah, that's really interesting about the emotion code. The concept of emotions being trapped inside our bodies is not one that's new. The Basil Vanderkork and all those folks, probably butchered that last name. It's been a while since I read it.
Bessel Vanderkork.
There we go. Yes, thank you. That's not a new concept, right? There are some pain-specific therapies that have come out recently that are gaining traction in the field, including pain reprocessing therapy, as well as emotion awareness and it's EAFT, and I can never get the exact words down. But again, that one's kind of gaining traction in the literature. Good luck with your certification. It sounds like a great opportunity. I appreciate the compliments, and I think that's it. Any other questions from folks who'd like to come off mic and share?
Yeah, when can you come back? That was amazing.
I appreciate that, and I'd love the opportunity. Like I said, we've got several really cool things we've tried out, including Dom Fast Track. I didn't get a chance to talk about that, but long story short, we reduced wait times for our inpatient substance use folks by 74%. It was taking them over 6 months to get in with my IDT team, and we got it down to under 30 days. So I'd love to come back and be able to talk about those kind of things.
Can you just, are there people, let me just say this, you must have had people coming into the program on opioids. Were there people what percentage of people went off opioids?
Yeah, that's a great question. Prevail is unique in that we don't actually take over opioid prescribing as part of the team. That is changing. Remember how I said this is not independent of clinical practice. So we're actually adding on additional opioid management in our pain management team. So we will take a look at that soon. What we do know is that on average, people are reducing their opioid use, which is interesting because we're not touching them, right? We might make recommendations in the chart, but it's typically their primary care who's prescribing. We also know that about a third of the people who engage in Prevail IDT track tend to be prescribed opioids. And so I'm really curious to see, once we have some data to look at as to if folks who are on opioids or medications for opioid use disorder, are they responding differently to interdisciplinary team treatment? I don't know. Lots of exciting questions to answer. All right, other questions?
Anybody else?
Anybody else want to unmute and ask? I don't know if I don't think we hit my other question, did we?
Oop,
Did I post it in there? I'm just wondering if there were certain types of pain that seem not to respond as well.
Yeah, and I think I had mentioned it real quick. So there's three main, and I should have mentioned that in the beginning for background. For time's sake, I cut it. There's three different types of pain based on the most recent classifications. One is nosoplastic, which tends to be, really complex pain that's really influenced by central sensitization and emotions and thoughts and all that. There's neuropathic pain, which tends to feel electric and kind of be nerve central. Then there's nociceptive, which tends to be, acute and kind of injury focused. It's interesting because most people don't just have one, right? Most people have overlapping pain conditions. So it's going to be an interesting kind of research approach to try to tease out because not a lot of people only have one. So I don't know. But it's something I'm really excited about looking at.
Okay.
I do have one, and it's a little off topic.
Yeah.
I work a lot with justice-involved individuals, and there are several veterans in that population. And I was talking to one of them a while back, and they brought up ibogaine, if I'm even saying that correctly. Mm-hmm. Are there any studies going on with the VA? Because I've seen things circulating about that.
That's a great question, and it's not my area of research, so I'm not sure. I will say that, especially in chronic pain, there's been kind of a shift in VA as to what the priorities are, right? Because that changes all the time. Pain and substance use disorder, specifically with opioids, is one of the highest priorities for VA research. They actually created their own portfolio called Active Management of Pain, and it's specifically related to pain and opioid use. So I think that if we don't have studies on that, I imagine they're going to be coming down the pike pretty soon.
Awesome. I was fascinated by this. They talked about the dosing and how it completely takes away cravings. And I was just like, wow, this sounds too good to be true. Tell me more.
It's the researcher in me, right? I always get a little suspicious when people tell me it fixes everything.
Yep.
But anyway, well, thank you guys again for the time. This was really nice. So thank you for your wonderful questions and for your interaction. This was awesome.
Sounds good.
All right, thanks so much.
Not a problem. Bye, guys.
Bye.
All right, everybody. We'll see everybody next week, 2 weeks from now, not just one. If there's any questions, please reach out to Katie. And otherwise, we'll see you then.